Thank you for allowing us to sit down with you and talk about this. Very important issues going on.
Mm-hmm.
I thought I would start by just asking you, sir, what your reaction, your personal reaction from the Supreme Court's ruling on Thursday, June 29th, and what you thought of that.
It surprised us. I mean, it surprised a lot of us. I've been working with the Society of General Internal Medicine and Health Policy, and most of us thought the ruling was going to go in a different way. So it was a very good surprise. I think, the history of healthcare in the United States is starts and stops. And historically, we've been pushing over the course of over a century to try to get universal access of all citizens to basic healthcare services. And this pushes us a long way toward that goal. It's a triumph for uninsured people. And there's, almost 1 million uninsured in South Carolina. Huge number of them are going to derive benefit from this. Now, is there going to be changes? We're going to have to change. The delivery system's going to have to change. The insurance industry has to sort of respond. Everybody's going to have to respond. But the people who win are people who otherwise don't have insurance. And the Kaiser Family Foundation suggests that probably 50,000 Americans die every year because they don't have insurance. And that would be about 2,000 folks in South Carolina who die just because they have no insurance. So it's a triumph for them, too.
I thought maybe you would just do a brief summary of your interpretation of what was ruled by the Supreme Court.
Sure. There were three aspects that they looked at. One was, did they have any sort of judicial oversight of the bill at all? And that was pretty clear, yes. So the second was the individual mandate, as it was called, constitutional? In other words, can the federal government require individuals to buy an insurance product because they say so? And that was the big controversial part of the bill. Many times, for example, car insurance. So that was one of the sort of analogies. But car insurance protects the person who's hit, not just the person who's driving the vehicle. This is requiring people to buy a product that they may or may not need or use. Most of them won't need it. Most of them are healthy. Most uninsured in the United States are working. About 75% are in families that have somebody working. But they're relatively young. Insurance is really expensive, and so they opt not to get it, or their employers opt not to offer it because it's so expensive. This basically says, if you're hit by a bus and you're in the emergency department, you're going to get care. Someone's going to pay for the care. It's obviously not going to be you if you don't have insurance. This basically says, well, you need to do your part. So that was the individual mandate. The third part was the entire validity of the bill. And obviously, if the individual mandate was constitutional, then the rest of the bill was constitutional. So it was great from that perspective. The downside, though, was the stick in the bill for states to expand their Medicaid programs. The way people are offered insurance or offered coverage in the bill is a variety of mechanisms. If you have a job, your employer has to offer you insurance or has to make sure that you have an option of getting insurance. If you don't get offered insurance, they're penalized. If they do go out and get insurance for all their employees, they have a tax incentive. So some of the cost of that insurance, which is gigantic for small employers, is offset by a tax benefit. On the other hand, if you don't have an employer who can get to that point, Medicaid's expanded. In South Carolina, the Medicaid enrollment is 42% of the federal poverty level. And no adults are covered unless it's a woman with children. This expands Medicaid to 135% of federal poverty level for all residents of the state, all citizens of the state. So it's a big expansion of Medicaid. In the first couple years, all of those costs are covered by the federal government. But down the road, in 2017, part of those costs revert to the state. In the bill, the leverage for states was to participate in the Medicaid program, you have to participate in the expansion. And what the justices said was, you cannot cut off core Medicaid funding to states if they refuse to participate in the Medicaid program. Expansion. So this expansion is a big part of how uninsured get coverage through expansion of the Medicaid program, and the leverage within the bill was weakened by that second part of the ruling. So it's a win for uninsured, but it's still a debate between the federal government and the states about the Medicaid expansion. It sounds like most states are going to expand Medicaid. Governor Haley has come out and said she does not want to expand Medicaid. But I suspect that there'll be a lot of pressure on Governor Haley and other governors, Rick Scott in Florida, to expand Medicaid because of the incredible amount of federal dollars that come into a state when you expand Medicaid. So it's going to be an interesting debate over the next year of whether the billions of federal dollars that could come into the state if you expand Medicaid is worth planning the downstream cost to the state, which is off in 2017. Not that it's small, it's a big expansion cost. It could be up to $500 million. But there's many years to plan and figure out how to do it. The insurance industry uses a technique called rescission, which is probably the most egregious of the insurance company techniques to stop paying for services. And that is when an insurance company discovers that maybe you had something that might have been related to this diagnosis before you were insured, they cancel your policy. And that is probably the most egregious of the insurance strategies, because now you have a diagnosis. You might have, say, breast cancer. And because you had a breast biopsy 15 years ago, the insurance company uses that to cut off your coverage. So that's illegal now. Another one is the pre-existing condition exclusions. Because the mandate was found constitutional, the insurance industry has said, if you mandate that everybody get insurance, then that means we'll bring in healthy enrollees. And so those healthy people paying premiums will offset the cost that the insurance company bears for sick people. If that weren't the case, then someone who comes in, someone would only enroll in insurance if you had a condition, a problem. So you get all the sick people, but you don't get the well people. And that was a big part of the individual mandate. So pre-existing conditions or pre-existing condition exclusions are not allowed anymore. Another one is lifetime cap. And we at MUSC, we see people who have chronic illnesses that are genetic. For example, cystic fibrosis, sickle cell anemia, services, huge service delivery to keep their disease under control, all the way to, say, a lung transplant or a heart transplant. Those are incredibly expensive procedures. There was $1 million cap on lifetime benefits, and that's now also not allowed. And then finally, there's a big emphasis on prevention. So in the Medicare program, preventive services and screening services have no copayments and no deductibles. So if a Medicare recipient needs a mammogram or a colonoscopy or a flu shot or a Pneumovax pneumonia shot, there's no copayments. So there's no disincentive to get preventive services. And that's one of the big parts of the bill, is moving healthcare from the back end, disease management and illness management, to the front end, to building a primary care system that supports prevention and early control of disease so you don't get the downstream horrible side effects of chronic illness.
Mm-hmm. What are we at MUSC doing? What changes are we doing in clinical care that is sort of helping in these areas?
So one of the new delivery models that is encouraged by the bill is called the Patient-Centered Medical Home. And a patient-centered medical home is basically putting the resources on the front end to manage a population of people. The way we kind of function now is, if you come see me, I'll treat what I see and we'll do preventive services. But I don't reach out to folks who don't come in because we're pretty busy in the clinic now. The idea behind the patient-centered medical home is, instead of just seeing, in our clinic in University of Internal Medicine, 200 patients a day, we have 12,000 patients that we have to manage every day. 200 of them come in, but the rest are still out there. And so we have a team that is built around managing the 12,000 and not just the 200. And so it's a population management strategy rather than an individual patient strategy. It takes a team. So we have, for example, 3 pharmacists we work with. All our nurses are being trained in population management and on chronic illness management. And the idea is preventive services, everybody gets preventive services. If you get a disease, or let's say you develop hypertension or diabetes, our goal is to control it so that you don't down the road, develop a heart attack or a stroke. So it's moving the services to the front end and aggressively controlling disease on the front end and preventing disease rather than treating it. The other model that's in the bill is called an accountable care organization. So if you take the concept of a patient-centered medical home, let's say University of Internal Medicine manages 12,000. Well, let's say you string together 15 or 20 of these patient-centered medical homes. Now you're in large numbers of patients. You have 150,000. Let's say you have 15 medical homes and they have 10,000 patients each. That's 150,000 patients. Well, what if MUSC as an organization took responsibility for those 150,000 patients? And on January 1st, they get a payment to manage those patients over a year. And within MUSC, the way we're organized, we would manage their care for a year for that payment. And it would be in our best interest to maximize prevention, to minimize progression of disease, because hospitalizations and emergency department visits are costly. Whereas if we can sort of control the disease on the front end, then the costs are less. And that's the concept of an accountable care organization. And some folks say it looks a little like managed care, but it really is not managed care. It's population management. It's where we take responsibility for a population of patients. We cover all their costs. We have all the resources. We have primary care, which I think will be expanding over the next few years. We have secondary care, all our subspecialists. We have hospital care. We have quaternary care, transplants, those kinds of things. So we can manage a whole population if we're organized to do it. And so that's the idea, is to organize to manage a population, not just individual patients. I know these are all long-winded answers.
No, that's okay. And this is happening, the patient-centered medical home is happening in internal medicine, family medicine so far, I guess, within our system.
Yes, and pediatrics is working on it. They're working with a statewide coalition to become patient-centered medical home certified. A big part of patient-centered medical home is the electronic infrastructure. And so we just implemented Epic, and Carolina Family Care implemented Epic. And so one of the things that we're thinking about is Carolina Family Care will transition to a patient-centered medical home. And that would, so now in the Low Country, there's only 3 patient-centered medical homes, family medicine, University of Internal Medicine, and Palmetto, primary care. So the idea would be to expand the number of patient-centered medical homes to get an idea what the population that Carolina Family Care manages, and to focus them on primary prevention, secondary prevention, and then reduce tertiary services downstream. But it's what primary care docs have always wanted to do. It's just we're reorganizing to do it more efficiently.
And technology such as Epic is very interactive, not just with the practitioners on one end, but it's also interactive with the patients, being proactive
Yes.
in the healthcare too.
Yes. So a good example is I can tell if the patient I see today has a mammogram and a colonoscopy. How do I tell if the 11,000 patients I didn't see today have a mammogram or colonoscopy? Well, Epic gives us the technology to say, in my population of 12,000 folks, who do I need to focus on to get their preventive care done? Who hasn't come in? Who's gaining weight? Who's missing their flu shot? Those kinds of things. So it gives us the ability to manage the entire population and to focus our resources on bringing in folks who need preventive care. If we were working with 12,000 paper charts, that's impossible. So that's one aspect of technology. Another is to open access. I mean, we want patients telling us what's going on. We don't want them sort of calling in and leaving a message and we get to it by the end of the day and those kinds of things. We want to be interactive. We want to be available on the front end so that patients don't end up going to the emergency department for a problem that we could have managed in primary care. So it does facilitate access into the practice as well. And then finally, it actually helps us practice better, because we'll have reminders in Epic at some point in the future, reminders of things we need to do. It allows us to work in a team, so a pharmacist can look at my medication regimen and say, you know, Dr. Moran, you probably shouldn't use this medication. Maybe you could try this one instead because of side effects or whatever. And in aging, that's really critical. So it allows us to work in a coordinated team. And then finally, not surprisingly, as we've had before, our subspecialists, hospital folks, our hospitalists, all of us can communicate through the same record. And that's really, really important for coordinating care.
So improving quality care is
A big part of this. Remember what it was called, the Patient Protection and Affordable Care Act.
Mm-hmm.
And the protection part is to protect from insurance abuses, but it's also to sort of incentivize us to provide higher quality care.
Mm-hmm.
So one of the famous aspects of the bill is if our readmission rate is too high, that implies that the quality of our care or discharge planning or follow-up isn't quite as good as it could be. And so one of the stipulations is if you have a low readmission rate, you get an incentive payment as a hospital. If you have a high readmission rate, then you get a penalty as a hospital. And so we as a system are trying to figure out, so first we make sure the person's treated well when they're hospitalized. Second, we plan their transition back out to the community thoroughly. And then third, we make sure that they are hooked back up with their primary care or their specialist relatively quickly after they leave the hospital so that they don't end up coming back in and being readmitted. Mm-hmm. So there's incentives in the bill to change the way we practice in terms of linking hospitals, primary care docs, specialists together. And, you know, obviously, we as an organization, we're perfectly positioned to work on that.
Mm-hmm. Mm-hmm. Can you talk about how the new act or the new law will change the workforce, especially here at MUSC? How will it affect us?
So one of the big things about our workforce is we probably have a lot of specialists. We don't have enough primary care docs. And I think that's been true in comparisons, in international comparisons. Other industrial countries have provider ratios of about 40% primary care or 50% primary care and 50% specialists. In the United States, it's about 25%. And that number's dropping. Mm-hmm. And so one of the worries has been when we bring all these new people into the insurance, into being insured, or we bring them into an expanded Medicaid program, then we need more primary care. So that's one thing, is building out primary care. And we need to do that relatively quickly, because when Governor Romney enacted this healthcare reform in Massachusetts, there was a primary care shortage immediately precipitated. There were 300,000 folks who couldn't find primary care docs. They've geared up. And that's a complicated thing, because although medical students like what we do in primary care, the lifestyle's not what they're looking for. Mm-hmm. They don't like being on call a lot. They don't like sort of working in an environment where they're not supported within a team. And they don't like the sort of hamster wheel of seeing a patient every 15 minutes. And so we need to change the structure of primary care, how primary care is delivered, in such a way that it's attractive to graduates coming out. And then, not surprisingly, we have to fix the payment mechanism, because right now primary care is at the bottom of physician payment, and we have to fix that to incentivize folks to come in, you know, new graduates to come in. We also need to change the way we train, because we're now going to be training in teams, not in interprofessional teams. It's not, you know, the gray-haired doctor in a clipboard anymore, like me, in a clipboard. It's a complicated team with an electronic infrastructure, and we all need to be working together. So that means pharmacists, nurses need to be trained differently. Medical assistants become a huge, resource for primary care. And then even our registration folks participate in the way we manage patients coming in. They, in University Internal Medicine, they start our process off. It's critical that they be part of the team. And the folks answering the phone. I mean, if somebody calls in and cancels an appointment, that's an opportunity that we've now lost to influence care. So we need to make sure that they're not canceling because they're sick. They're rescheduling, they're sort of, or we're in touch with them about what happened. So every component of our system has to work together to maximize care for our population. Mm-hmm. And so each one of those, we're going to need more pharmacists, I'm sure. Our nursing training is going to be different. Nurse practitioners, PhD nurses, physician assistants, all of them are going to be working in a new primary care delivery model.
Tort reform.
Yes.
How,
Wasn't really big in the bill. I know. Think that might be because pretty much everybody writing the bill is a lawyer? So, tort reform is a huge issue. And there are a number of strategies that states have used. I mean, basically, I think the bill avoided tort reform by saying it's a state issue. I think, tort reform is a big issue, and everything couldn't have been managed in the bill.
explain, just to back up, explain what tort reform is.
So,
for people who don't know.
yeah, so one of the worries that many folks have is that providers order more tests than necessary because they're worried about being sued. And that, to some extent, is probably true. But a number of studies have also shown that actually the relationship between the provider and the patient is more important than whether someone made a mistake, and a mistake that resulted in harm. Mm-hmm. So tort reform is important. We need different mechanisms, but we also have to think about our risk a little differently. In general, primary care docs, for example, who have relatively good relationships with patients, aren't sued anywhere near as frequently as providers who have transient relationships with patients, or, for example, people who do high-risk procedures. So we need tort reform. We also need to think about our role in inciting suits. And there are a number of organizations that have looked at physician behavior, provider behavior, relationships between us and patients, and how that reduces our liability. So tort reform is part of it, but the other thing we have to look at is our relationships with patients, and how do we create an environment where we can be open about mistakes. I mean, we are not perfect, and our systems are not perfect, and things are going to happen that are mal-events or adverse reactions, and we just need to work with patients to say, look, I mean, that was a problem that we may have anticipated, we didn't anticipate. We're going to do everything we can to prevent it from happening in the future, and if you were injured, we'll take care of you. It's a strategy that other universities have looked at to figure out how they can minimize their sort of susceptibility to lawsuits. If we don't get costs under control, then the benefits we get are going to continue to shrink. Mm-hmm. So I think we are a big part of the problem as well as a potentially big part of the solution. We need to think differently. We need to be stewards of a resource, not just providing as many potential services as we can. We need to start thinking about how do we provide the services that add value to patients' care, and not just think about providing services that increase our volume and increase our revenue. And I think that's actually the fundamental challenge that faces the delivery system and insurers. I think the other thing is that employers are going to demand a different kind of service. I think we see employers saying, enough with 6 or 8% increases every year in our insurance premiums when our workers are only getting a 2% raise. Inflation is 1.8, but healthcare goes up at double-digit rates every year. They're basically saying, we want a different model. We want a model that maximizes value to our employers, their employees, but doesn't take every extra dollar out of the company. And that's a challenge that managed care faced in the 90s, and we're going to face again. It's about purchasing value and not just purchasing volume. And employers are going to say, I want value. I don't want to just pay for every widget that every doctor can order. And we as a delivery system have to think about how we do that in a different way. Because our system, like everyone else, we are volume driven. The more patients we see, the more things we do to them, the more money we make. We have to think about that differently. Otherwise, fundamentally, we aren't going to get costs under control.
Dr. Moran, we were talking about health insurance, and I thought maybe we would talk a little bit about exchanges in the bill and how that was sort of defined.
Yeah, that's an interesting phenomenon. When healthcare reform in Massachusetts went up, they needed a mechanism of marketing different insurance products and making sure that people who bought insurance products knew what they were buying. And they came up with the idea of an exchange, an insurance exchange. So, for example, a small business or an individual could go to these exchanges, look at the products that they could potentially buy, and I think there'll be silver, gold, and platinum, and what services that are covered, and then what the cost is. And I think introducing competition and transparency, both about cost and about covered benefits, is the basis of exchanges. So I think what we're going to see, and we're already seeing, is all of us are going to start looking for the best deal in insurance for how much, how many services we can get, what kinds of services that are important to me, and then what the cost is. Mm-hmm. The other thing that the bill included was a cap on administrative costs for insurance companies, which is now set at 20% administrative costs, 80%, or 80% of 80 cents of every dollar goes to patient care or quality. For Medicare, that's 94%. 6% administrative costs, 94% go to patient care or quality. So we're inducing insurance companies to be more efficient and also to be more transparent about what services they cover for what cost. And I think that's a good thing. It'll improve competition within the insurance industry. We'll have a better idea. And then I think we, as South Carolina state employees, start thinking about what is it we get? What is it the state employee gets? What does that cost? Are there other options? And start us thinking about being a value-based purchaser, not only of medical services, of hospital services, but of insurance products. So I think it's going to evolve over the next couple of years. And I think that's actually globally what this bill does, is it pushes us to evolve. It doesn't fix all the problems. It doesn't, it starts us on a road where I think we can address problems from a different perspective, that we're actually going to look at it from a value perspective, from a prevention perspective, improving competition, being more transparent about what we do, focusing on quality, focusing on efficiency, and being much more patient-centered. And I think overall that's where the bill brings us. And like Medicare, Medicare was enacted in 1965, and there was a bill changing Medicare every year since 1965. And that's the way this is going to be. This is not static. We're going to evolve from here to what I think is more citizens who have insurance and a hopefully different delivery system that's now much more focused on efficiency and value and less on volume.
There's been some things in the press talking about lawmakers wanting to repeal this bill. What is the possibility of that, and how will it affect things as it stands right now?
Well, I think Representative Boehner has actually, I think, called for a vote this week on repeal in the House of Representatives. And that vote will pass. And actually there was a repeal bill, 4 or 6 months ago, or maybe close to a year. And it passed the House of Representatives. It was never introduced into the Senate. And as you remember from, Government 101 and civics back in high school, a bill has to pass the House and the Senate and be passed and signed by the President to be enacted. What's happened is the House of Representatives can pass a repeal bill. The Senate, supporters of repeal would need 60 votes, and that's not likely until this upcoming election. And even if they got 60 votes, President Obama has vowed to veto it. So you need all three, the two houses and the president, to be aligned in repeal before you can repeal the bill. Mm-hmm. That is why the focus of the upcoming presidential election, some of the Senate seats that are up for re-election, senators up for re-election, that's why they're focused on that. Because you need 60 votes in the Senate and you need the president to repeal the bill. Mm-hmm. And if President Obama is reelected, even if the Senate does sort of go to 60-40, he'll still veto the bill. So I think the likelihood of total repeal is pretty low, but it's a long way to November. So we'll see whether, the sort of planets line up and opponents of healthcare reform can repeal the bill.
Well, this definitely sounds like it is going to be a hot topic for debates coming up this late summer and fall, as far as healthcare being probably at the forefront of discussion from the candidates.
Mm-hmm.
And hopefully more information and details will come out of what how the law is going to be explained
Yes.
and interpreted by the people.
Remember that proverb, may you live in interesting times. The next 4 or 5 months are going to be interesting times.
Is it too early to ask, is it a good time in healthcare today in America? Or should we still wait until 4 months from now?
After the election? I think it's a good time now. I mean, a number of these changes have been put in place already. The insurance reforms are in place. We're going to go forward with constructing exchanges. This is going to progress as if there are no more barriers to healthcare reform. I think what we need is smart people to help put in place the changes that we need to be able to respond to the mandates of the bill. And I think here at MUSC, we're aligning folks to do that. I think many of us think that even if parts of the bill are repealed, this is where we're going to go in healthcare delivery, that we're just spending too much money and we're not adding value to services. And so I think our leadership here is pretty much aligned that we're going to focus on value-based services. We're going to realign our delivery system slowly over time to start meeting the challenges that we think are coming under healthcare reform.